okay? Doctor is checking like lower limbs for about pitting edema, okay? Pitting edema, what cases we have?
Right side.
Heart failure, what else gives you pitting edema?
Kidney failure.
Kidney, liver failure, when we have low albumin levels, okay? Because protein albumin like holds the fluids, water in the vessels, okay? When it's low, it goes to like tissues. Okay, patient has orthopnea, sitting position the patient is. Patient has, of course, as you see, very high respiration rate. Let's look at monitor, all vitals is on there. Just they are doing A, B, C, D, E, and air we don't need like to open airways. Patient is conscious. Just they gave oxygen. They start for IV insertion, monitoring. As you see, like itself on the stomach, there's a paradoxic like breath. You see? Okay. And they're going to do CPAP ventilation. What I told you. Okay? Positive pressure ventilation. By ventilator, it's very relieving for the patient because needs less power to breathe, okay? Now she tries to insert the vein. It's very dangerous like condition of the patient because anytime is possible more pulmonary edema and hypoxia, cardiac arrest. Look at screen. What we have here, right? Or clear. What vitals we have problem?
The respiratory rate is 34.
Everywhere,
Yeah.
okay?
Yeah.
Pressure is 200, respiration rate is 34, SpO2 73, heart rate is almost 120, and looks like here is like
We don't have-
in
yeah.
one complex we have. What is it? What do you think? This one? It's a different.
We don't have here.
That's a PVC,
Yeah.
premature
Yeah,
ventricular.
yeah, exactly, yeah.
Ventricular has different shape, okay? But it's nothing. Here is not about this problem. Here we have problem, okay? Just imagine. Okay, now what would you do? It's your patient. How to manage? Okay, we started CPAP ventilation, okay? We use like mask. Patient has like CPAP, it's very good. But what about drugs? What would you use to stabilize this patient? Pressure, heart rate, SpO2, okay.
We should
But-
give him nitrate.
What?
Nitrate. Nitrate. or-
Nitrates.
Nitrate.
Nitrates. We can give. What side effect of nitrates after we use?
Relaxation of the.
Assist mechanism.
Side effect, I
Side.
mean, not like we know that it's vasodilator,
Yeah.
decreases preload, afterload, and for the heart it's great, and pulmonary edema cases. But we have to know what changes we have after. Increases the heart rate, okay,
Mhm.
a bit, but increases. We have to know about it. When we have a patient with tachycardia, so severe scenario, sometimes after nitroglycerin I use morphine.
Oh.
Morphine also decreases like pressure, preload, okay, vasodilator is, and patient is better, okay, relieves pain, because now patient has stress, because can't breathe. Now, epinephrine, cortisol itself very high, okay, we have everything increased, and patient, it's just imagine you're fighting against the pressure, but still you have problem. Morphine, that's why it does very good in that cases, but morphine also, just imagine patient is already like exhausted, and after you give morphine becomes more exhausted and maybe just stops breathe, okay? And that's why we must be very, very careful, and we decide what to do. It's on you, okay? You are doing assessment and decide what to do.
Doctor, I have a question. When we can use the fentanyl?
Fentanyl?
Yeah.
Fentanyl we use for intubation.
Only for intubation.
Yes, only. Just for analgesia, better to give Promedol or morphine if patient has pain for a fractures or like that, okay? What about diuretics? Would you give diuretics to this patient?
If we have
To
pulmonary
decrease
edema,
the-
yes.
Yes, of course. What diuretic?
Furosemide.
Loop diuretic, yes.
Yeah.
Good. And we try everything, and later, okay, if it's not any improvement, of course, we intubate. We have no choice, okay? Just imagine patient is conscious, of course, but exhausted. Now, after CPAP, increased saturation, it's better, but it's not that all. Of course, they gave already furosemide, CPAP ventilation, nitroglycerin. We will see that pressure decreased, but okay, they're rating for a while, of course. We are not going to intubate immediately, okay? We have to stabilize for try, because intubation is not like treatment, like, okay, it's the last what we do when when we can't avoid it, of course. Just imagine how he is breathing. Still sitting position. Because diuretics won't work. After nitroglycerin, we have decreased pressure, but you see heart rate increased, okay? It happens.
Cardio,
Patient head motion also gives you like sign that not everything
Good.
is okay yet, okay? Seriously,
Yes, but
they could not like remove all clots. I'll cut these clots, okay? Don't try to ask patient to lift a bit, because one step for the patient can be mortal, because it increases more, okay? Pulmonary edema and exertion must be avoided, okay? And of course, after they have not any like improvement, patient still on the mask, still has like so severe dyspnea, and we can't wait, because now diuretics won't work. Why? Because all blood is like concentrated to respiratory muscles, okay? And kidney, by epinephrine, we have constriction, okay? Diuresis is not enough. Well, now let's see what they're doing. I'll go a bit forward. Okay. They're preparing for intubation. It's not any coma patient, it's not any cardiac arrest, but patient needs ventilation because it's impossible to manage. Was not impossible, but some cases without intubation we can recover, like improve the patient's condition. Patient has still brief, of course, they will give drugs. They use propofol, they use neuromuscle relaxants, fentanyl, of course, and after they intubate.
They have to give him muscle relaxant?
Yes. And you see now it's so different, not always like what we see. Here is so narrow, just imagine. So narrow, and there is also fluids, okay? Because there is a pulmonary edema, and pulmonary edema cases, they have cough sometimes with bloody sputum, okay? Because alveolar like bleeding we have, because so high pressure is in lungs. Not so easy to insert there too, but we have to try. He has direct control. He's not looking at the screen. Because it's not so easy, that cases. So many sputum there. And after insert it, okay. It's very high pressure on you, because if you can't and delay or insert in esophagus, okay, you waste time. And for this patient, hypoxia is mortal, of course. Let's see if they auscultate after. Okay, they do auscultation. They ventilate still with embu bag yet, okay? But better to check with embu bag than because it's more audible, of course, ventilation. And you see, there is so much like fluids in tube because patient had edema. After must be done suction, of course. And patient now can have diuresis better because relaxed, pressure dropped, okay. And after like these drugs, always pressure is going down, okay. I have here training video laryngoscope. I'll show you how it looks like from inside. These dummies, oral cavity, larynx, epiglottis, okay, pharynx, because to be more confident and must be familiar to you what's happening inside, because that was real cases. But here a bit different looks like, but in real scenarios you will have maybe bloody oral cavity, maybe it's a trauma, okay. That's why when we know how to like do it on basic level, later you can like, for example, do it more easier, of course. Just have in mind that that's very important, okay, and there is no other chance to survive. You can do CPR, you can do defibrillation, but it's not enough. Okay, that's not real, but for finding out and in difficult airways, you see the difference? This blade and this blade, it's so carved, okay? And you, because of these cases, you can't see anything from the mouth. These cases, you can see directly trachea, but these cases you have to look on screen, okay? We use these video laryngoscopes in cases when we have difficult airways, because as you see, it needs time for preparing, okay? It's not like urgent scenarios, but when you have no choice, you have to try with video, and late after is surgical airways, okay? Let's see. First, okay, we see the tongue. I'm going down, and what is it here? What appeared first? This
It's
one.
epiglottis.
No, this one. Uvula, yes, okay. That's the basis of the tongue. I'm going farther, and you see, I'm basis of the tongue, and I see part of epiglottis. What I see down, okay, is esophagus.
There's a tooth.
Yes, esophagus. Where is that tube? Here it is. I want to show you this. Okay, I'm inserting now this, and it goes directly in esophagus. You see, it's esophagus down. Okay, and now I'm going to be close to epiglottis. Okay, here is esophagus. You see, it's esophagus. Here is not seen any trachea yet. Now I'm going to lift it. You see?
Oh.
After I lift it, I see vocal cords, I see like a trachea. And I'm going to insert there too, okay? Of course, control is by a screen, and I can't see anything from here because it's with the laryngoscope, okay? Different shape. Now I'm going to like lift it, okay? And as you see, so easy is to insert in esophagus, okay? It goes in esophagus directly, not up. That's why I want to have this card, okay? Because it does go in esophagus, as you see, okay, down. And I will insert there. That's why I must go up. I will give a shape to this. Of course, we do lubrication. Very important. Lubrication is happening inside of the package. Okay, we don't remove it because it must be, okay, it's impossible to be sterile because we go through the mouth, and in mouth we have billions of bacteria, okay, but still we have to be careful about it, okay. Now I'm going to, like you see, insert here. While I cover these two stripes, I can stop because I exceeded the vocal cord. That's the first confirmation that I'm inside, okay? Not in esophagus, I'm in trachea, okay? Another option is, if you go like exceed epiglottis, for example, like this way, you see so near you are to trachea, okay? You can do this way also, but why go so farther when we have like this option and better visual we have, okay? And we can control it. This way, you are so close, okay, you see the trachea, inside the cartilages, everything is possible to see. Now, when we use this one, okay, without screen, we just insert, okay, opening airways and trying to do same, okay, just from here. Find epiglottis, lift epiglottis and insert to trachea, okay? You see, I'm trying to don't push on upper, never do like that, okay? Just try to lift the jaw, okay? On real patient is more easier because it's a trauma mannequin, it's a stiff jaw has, okay? And when patient is relaxed, very easy, but sometimes patients are not relaxed and we have crash intubation. Crash intubation means that patient has cardiac arrest, just like had cardiac arrest, and patient is not relaxed. You have no like time to give it drugs, and you do crash intubation, okay? I'm in middle, okay, and I'm doing lift and insertion of the tube. You will find out this when you do with your own hands, okay? Okay, now let's do a bit break, and after we start